Welcome to Derm Drop. I'm your host, David Sider, bringing you quick picks from the dermatology literature and other interesting sources in the dermatology community. Episode 15 includes 4 segments, starting with hidradenitis suppurativa. There's bad news, there's good news, combination therapy is on the way. Followed by natural remedies for psoriasis, evidence-based recommendations for the patients that want them. Then the skin-brain axis, just like the gut-brain axis, only skinnier. And finally, that bad boy hydrochlorothiazide is added again, and this time it's gotten mixed up in the pathogenesis of actinic keratoses. Fun stuff per usual, so let's get started. First, the bad news. Hidradenitis suppurativa is on the rise. A meta-analysis published July 2025 in the Journal of Dermatology put the global prevalence at 2.5%. But the authors admitted that heterogeneity and sparse data from the global south requires cautious interpretation. So let's go with the more conservative estimate of 1%, calculated in the meta-analysis published August 2025 in JAMA Dermatology. Compare that to the 0.4% rate from the meta-regression analysis published May 2021 in JAMA Dermatology. That's a big jump in just 4 years. As rates of HS increase, our understanding of its cardiovascular risks is increasing too. A review published in the July-August 2025 issue of JCAD and PPA Perspectives in Dermatology found that HS patients have elevated risks of myocardial infarction and ischemic stroke that are even higher than psoriasis patients, and their lifespan is 5 years shorter than controls. Systemic inflammation is a cardiovascular risk factor independent of the obesity, metabolic syndrome, and smoking, which often accompany HS, as pro-inflammatory cytokines such as IL-17 and TNF contribute to atherosclerosis and thrombosis. And HS patients have lower levels of cardioprotective endothelial progenitor cells. HS patients have higher infection risks too, according to a study published in the February 2020 issue of the British Journal of Dermatology. And that risk is reflected in adverse event rates, as a study published August 2025 in JAMA Dermatology found that HS patients on adalimumab had more serious infections than psoriasis patients on it. The good news is that combined therapies are on the way. Phase 2 results of a TNF plus OX40 ligand nanobody reported August 2025 in the Journal of Allergy and Clinical Immunology showed more potent inhibition of T-cell activity than monotargeted therapy. So far we have OX40 blockers like Amgen and Kyowa Kirin's rocatinlimab and Sanofi's amlitelimab in phase 3 trials for atopic dermatitis. But the pathway is pathogenic in HS too, so keep an eye out. Guaranteed a good chunk of your psoriasis patient population is on community forums getting advice from their peers on what natural remedies have worked for them. In fact, an estimated 42 to 69% utilize complementary and integrative medicine, with herbal medicines comprising the most prevalent choice. Our role as dermatology clinicians is to help them sift through the competing narratives with evidence-backed guidance on which recommendations are more likely to be safe and effective. With the systematic review published in the June 2025 issue of Complementary Therapies in Medicine, that vast natural terrain is now a little more navigable. The study evaluated 20 randomized controlled trials involving 1,115 patients. The remedies that had the best evidence were Indigo naturalis, Mahonia aquifolium, and aloe vera. Indigo naturalis outperformed calcipotriol. Just be sure to recommend a blue-free formulation so you don't get an angry call about stained clothes. Mahonia aquifolium beat the vehicle, though in one study only the patient-reported outcomes were statistically significant, but it's their opinion that matters, right? Aloe vera had mixed results, but outperformed triamcinolone 0.1% in one study. However, dryness was reported by some patients. Remedies with promising single study results included turmeric, St. John's wort, boswellia, and chamomile pumpkin seed. Interventions that did not make the list included avocado oil, kukui oil, and oral evening primrose oil. All of these were topical preparations with the exception of turmeric, which was effective both topically and systemically. Adverse effects were mostly mild and comparable to those in the control groups. For the patients on the milder end of the psoriatic spectrum that don't want a topical steroid and for whom novel non-steroidals are out of reach, give them these herbal ingredients to plug into their Amazon search. It'll give you some naturopathic street cred and go a long way toward dispelling the belief that you're just a cog in the pharmaceutical wheel. By the way, do vitamin D analogs and phototherapy count as natural? Asking for a friend. You've heard of the gut-brain axis, right? Well, there's a skin-brain axis too. Dermatology clinicians know how impactful skin diseases can be on the emotional and mental well-being of patients. We think of it in psychological terms, like when the patchy dyspigmentation of vitiligo affects a patient's self-esteem, or the maddening itch of prurigo nodularis causing anxiety, or the pain and social isolation of hidradenitis suppurativa leading to depression. But those psychiatric comorbidities have a direct pathophysiological connection to what's happening in the skin at the molecular level via bidirectional communication between the skin and brain. Check out these recent findings. An August 2025 article in Psoriasis Targets and Therapy describes the pathophysiologic mechanisms by which psoriatic inflammation breaks down the blood-brain barrier, allowing Th17 cells and cytokines such as TNF-alpha and IL-17 to migrate into the brain where they contribute to depressive symptoms via a number of pathways. An August 2025 review in the Journal of Dermatologic Science describes how chronic UV exposure induces alterations in neurotransmitters such as glutamate, dopamine, and beta endorphins, affecting learning, memory, and emotion regulation. UV radiation also activates the cutaneous hypothalamic pituitary adrenal axis. Yeah, that's a thing too. Activating the skin HPA axis results in increased cortisol levels and impaired neurogenesis and cognitive function. So sunscreen protects the brain too? Looks like it. Just like in the gut-brain axis, microbes play a major role in the skin-brain axis, except of course it's the cutaneous microbiome at work. Microbiota diversity and the postbiotic short-chain fatty acids it produces support skin barrier integrity. Conversely, microbial dysbiosis leads to a disrupted barrier and subsequent neuroinflammation and dysregulated stress hormones. And stress can further alter skin microbiota composition, creating a feedback loop that amplifies both dermatologic and emotional symptoms. So the skin is home to a neuroendocrine system that communicates and interacts with the central nervous system, resulting in reciprocal modulation of a wide array of neurotransmitters like serotonin and neuropeptides such as corticotropin-releasing hormone. Just watch a rosacea patient to see this complex interplay in action. So what does all of this add up to? Understanding these mechanisms helps clinicians provide empathic holistic care and scientists develop therapeutics that address and leverage this interconnection. There's even talk of quote-unquote neurocosmetics designed to elicit psychophysiological responses that enhance emotional well-being as well as skin health. So whether you call it the neurocutaneous system or just the skin-brain axis, it's a thing. And finally, what's your biggest red flag in the med list? For many dermatology clinicians, it's hydrochlorothiazide. HCTZ has been implicated in lichenoid drug eruptions and drug-induced subacute cutaneous lupus erythematosus, or SCLE. But HCTZ's role as a photosensitizer may be its most concerning cutaneous adverse effect, and epidemiological studies have correlated its use with increased risk of non-melanoma skin cancer. In fact, the European Medicines Agency issued a warning regarding the risk of developing non-melanoma skin cancer from thiazide diuretic use in 2018. So it's not surprising that evidence of its role in actinic keratoses is mounting. A study published in the June 2025 issue of the Journal of the American Academy of Dermatology combed a large population database for patients on antihypertensives and found that those on HCTZ had the highest rates of actinic keratoses treatment with rounded risk ratios as high as 1.5. In other words, patients on HCTZ were up to 50% more likely to require treatment for AKs compared to those on other blood pressure medications. So when that super scaly patient groans as you walk in with the liquid nitrogen, refuses to do FUDEX ever again, and white-knuckled it through their one and only PDT treatment, you might be able to get ahead of the never-ending game of whack-a-mole by working with their primary care provider or specialist to swap out their HCTZ. Work smarter, not harder. And that wraps up episode 15. Derm Drop is written and hosted by me, David Sider, with production, distribution, and promotion by Jacob Gary. Full text and links to the articles discussed in this episode can be found at linkedin.com/in/Dave-Seiter, spelled Seiter. Questions and comments can be sent to us at dermdrop@gmail.com. And if you learned something useful or interesting, hit the thumbs up button, rate and or review, and be sure to tell a friend. Thanks for listening, and tune in again in 2 weeks for more dermatology quick picks in the next episode of Derm Drop.